Welcome, everyone. This is our community education webinar. I'm Dee Childers with Life Changes Elder Care Consulting and Vice President for Learn and the Community Education Coordinator. And our topic today is benefits of palliative care. Learn is Lifelong Education and Aging Resource Network, and we are an Idaho-based nonprofit providing community education on aging and caregiving topics. Learn is part of the Society for Senior Advisors Leaders Network, and the content today is provided for general information purposes only and is not to be considered legal, financial, or health advice. Our sponsors today are Oasis Senior Advisors and A Mind for All Seasons. Our sponsors have sponsored all of these education sessions that we have in this quarter, and we greatly appreciate them making this sponsorship to Learn so that we can provide this education to you all free of charge. And so we thank you very much. And today our presenter is Dr. Jessica Evert from St. Luke's Palliative Care. And I did that one too many, even with my notes. So Dr. Evert is a physician leader with over a decade of experience in palliative care, hospice, hospital medicine, and organizational leadership with broad-based training in family medicine and primary care. She has served in multiple leadership roles, including executive director, hospital site director, oversight of continuing education programs, CMEs, I'm assuming, evidence-based medical reviews and updates, the ethics committee chair, and made numerous contributions to multiple continuous improvement initiatives. She is nationally and internationally recognized expert in community-based engagement, health equity, global health, and medical conditions. Dr. Evert is dedicated to quality care for all patients with a passion for underserved populations, value-based care, palliative care, and health quality. She's also, in her spare time, a researcher with experience in both qualitative and quantitative methods to drive evidence-based practices, capture the burden of disease, and continuing quality improvement. She is a contributor to institutional and national efforts to optimize diversity, equity, and inclusion in all aspects of healthcare. Dr. Evert is board certified in family medicine and hospice and palliative care medicine. Dr. Evert, please, we welcome you to our presentation today.
Thank you for the warm welcome. It's wonderful to be here. As Dee mentioned, I'm Dr. Jessica Evert. I am with the Palliative and Supportive Care Department at St. Luke's here in Idaho. Also work as a hospitalist, and I'm on faculty at UCSF. I really appreciate this gathering and the sponsorship as well. I think this is so important, and I've been able to see peripherally a variety of the topics you guys have been exploring, and it's just wonderful to be a part of this community. So thank you for welcoming me. I wanted to start off with introducing you to a few patients. The first is Marcia, who's 78 years old. She has heart failure, and it's increasingly kind of affecting her daily life. She's having harder time breathing, walking, going to lunch with friends, and going to church as she used to. And then there's David. He's 68. He has a chronic lung illness called COPD. He has to use oxygen day and night, and he's taken lots of medications, including lots of inhalers. He is getting more short of breath, but also losing a lot of weight, and as a result, feeling much weaker. And then there's Donna. She's 46, and she has liver failure from hepatitis C, which is a viral infection. And she was recently hospitalized, and the doctors told her that she may not make it out of the hospital, that she may die during the hospital stay. She did get out of the hospital, and she got referred to a liver transplant, but there's quite a waiting process for that. And so currently she's waiting for the liver transplant and experiencing a lot of itching, having intermittent confusion, and abdominal pain. And then Emmett is 98 years old. He's really gotten to almost centenarianship with little to no medications and really no doctor's visits. He's doing great until he trips on a rug in his house and falls. And he has a hip fracture and he's in the emergency department. His daughter's with him, and he's facing the decision on whether to get a surgery or not for his hip fracture. So with those patients in mind, today we're going to talk about the benefits of palliative care. Palliative care really focuses on suffering and quality of life. And this conversation is not just relevant for those of us in Idaho, but is really a global conversation that's happening because healthcare and medical care has really evolved in a way that sometimes the experience of disease is takes a back seat to labs, medications, imaging, and there's a fair amount of suffering, impacts on our daily life and our quality, and they can be physical, they can be psychological, they can be spiritual. And so a lot of folks are speaking up that palliative care is essential. And it's estimated that only 14% of patients who need palliative care who benefit from it actually receive it. So when you look at like the technical definition of palliative care, there's many of them, but I like this one in that it's a specialization of medical care for people who are living with serious illness. And that illness can either be a chronic, long-term illness that's never going to actually completely go away, or it could be an acute episode of illness that has a lot of symptoms, such as pain, difficulty breathing, etc. And the care is really focused on providing relief from symptoms and also addressing the stress of the illness with the aim of improving quality of life. So I wanted to pause and ask you, I'd really like this to be a conversation as much as anything. So interruptions are gifts, and I would just like to ask you if you would be willing to unmute and speak to number one, who you are, where you're coming from, but also if you have any experience or you've ever heard of palliative care, if you could share some of those with us, just so we can understand the shared experience we've all had.
Well, I'll start because that's how I met you, Dr. Evert, was with one of my clients through Life Changes. And you were very new to St. Luke's at that point in time. And I was so thrilled to meet you. I have had, and I believe my client has had such an excellent experience with palliative care. And I know it's like many people, they get confused. Is it just pre-hospice? It's hospice with a different name, and it is not. And my client is an 89-year-old woman who has many health conditions. And it's just a lot to manage. It's a lot to have in the air, and to have a whole team that's focused on helping us make sense of the bigger picture. We might be to 3 different cardiologists. Who knew cardiologists had plumbing, electrical, specialist with different parts of the heart. There's all sorts of things. And the palliative care team has just been a wonderful kind of comforter to help us navigate the system, sometimes to get into providers that we might not have known about or couldn't get into. And so my client has had great relief and some great benefits from having the St. Luke's Palliative Care team as part of our team.
Thank you, Dee, for sharing that story.
I've had 2 different people in my life with experiences with palliative care, and they were 2 very different, one at each of the health systems here, and 2 very different experiences. And what I came away from is that I think it really has to do with the person. Like my younger brother had colon cancer and has since passed away. But when he was in palliative care, he was overwhelmed because about 5 people came into was a very quiet, shy guy, and he had the social worker and the chaplain and a doctor, and there were like literally 5 people that just came in, and it was very overwhelming. Then the other experience also with him, this was a couple years later with it's a long story how he ended up at both places, but it was just one person. And for him, that just having that one person, and she knew him because he had been in and out of the hospital for a couple of years, and she just told the rest of the team, we just need to have one person talk to Tom. And so it's interesting how, I don't know what I'm trying to say, but just based on his experience, I really think it just depends on the person, how they respond to it. So.
Yeah, Mary, I really appreciate that sharing, and I think, yeah, you bring up an important point. Like, it's really about meeting the patient where they're at and what their preferences are, and healthcare is often not designed to do that. And so palliative care really tries to make that front and center. We don't always succeed, but that's the framework, which makes such a huge difference. And then what you mentioned about continuity, I want to explore that more during our time together. But having the same person meet with someone, especially in different care settings, like it's now medicine is such that like you have your outpatient primary care doctor and your outpatient oncologist, and you have an inpatient hospitalist, and you have the inpatient oncologist. It's different than the outpatient, and it's very hard for people during their journey to have that accompaniment that can make all the difference. So I really thank you for sharing that, and I'm sorry about the loss of your brother too. Other experiences with palliative.
So I'll share a couple. I'll turn my camera on too. I try to turn it off so that I don't have problems with bandwidth, but hopefully it'll work. So we've had two as a family, and both were for my in-laws. And the experience is very different, mostly because of where they entered into palliative care in their journey. My mother-in-law actually went into the hospital with the flu and very quickly declined. And by the time we entered into palliative care in the hospital setting, it really was to support the family and in our choices and helping to fulfill her preferences and honor her preferences at the end of her life. And so it was really an end of life palliative care experience, but very positive. And we were grateful for the approach and for the vocabulary and the ability and to make decisions as a family and feel supported in doing so. My father-in-law, on the other hand, is in stage 3.5 kidney failure. Maybe it's 3.9, so he is choosing palliative care in how he addresses and deals with cardiac events, and how he addresses and deals with individual kidney events and other things, and is very active in his palliative care choices with his nephrologist in this case, right? That's his primary person, and the choices that they've made together and continue to make ongoing at every meeting. And I would say that he's now into maybe his second year of palliative choices with a care provider.
Thank you for sharing that. And that does bring forth, the contrast of how, what a wide spectrum palliative care is. And certainly at times in the hospital, especially in the ICU, it is that sudden, end of life situation. And we're going to talk about, the whole breadth of palliative care, but I really appreciate that illustration because it's very flexible in that way too, in terms of how that care unfolds. Any other shares or thoughts on experience with palliative? Or questions you're hoping to get answered this hour? That would also help too. I want to make sure I'm being a good presenter.
Hello. I haven't had experience with palliative care, only hospice in the last few weeks of my sister's life and my father's life, and experience with home health care. And so I've looked at the Medicare requirements to qualify for hospice, and I'm not sure that we're there yet, and I'm not sure what the difference is between palliative care and home health care. So.
That's a right-on question.
Yep.
Yeah, thank you. I think that's the perfect segue, and I did not plant you to ask that question. But yeah, I really appreciate you sharing. And certainly I'm going to go through some of that, but if there's ongoing lingering questions, or I'm happy to talk one-on-one too. But you guys all, I think, many of you are alluding to some of the myths and misconceptions or understanding of palliative care. And I think one of the language we use, like you guys point out, is so important. And I would say there's stigma with the word palliative care, and then also with hospice oftentimes. And a lot of people think palliative care is hospice, or palliative care is only for people who are dying. Palliative care is for when, there's nothing left, or when, everyone else is giving up on someone. Oftentimes when people will come to their first appointment with me, and it can be scary because they're not quite sure what they're going to find, that the cardiology is for the heart, kidney, renal or nephrology for the kidneys, GI for the intestines, but what organ system am I taking care of? And so there's a lot of unknowns, a lot of lack of clarity, and I think it takes quite a bit of courage to even come to the first appointment. But certainly, the fear is that talking about things or working through things or bringing them to light, the fear that will affect someone's hope or even expedite their decline is certainly real for many people. Also, there's often kind of misunderstandings or concerns around the medications we use, and are they just more drugs, or are they going to create addiction? But that confusion with hospice is probably the most common confusion, and it makes sense why it's confusing, because it's confusing, and oftentimes terms are used interchangeably in different parts of the world. Different terms are used. So I'll try and distill that difference out a little bit. So hospice in the United States, oh, sorry.
I was just going to read one other person's comments. She doesn't have a mic, so she typed them in the chat. May I just do that real quick?
Please do.
So this is from Susan. After suffering years of Alzheimer's dementia, it looks like so I'm guessing maybe father, suddenly suffered a stroke and then weeks later had a major stroke. After initial ER and ICU care, I asked about having him evaluated by the hospital's palliative care team. That same day, I also had a hospice come and evaluate him. They worked together seamlessly, is what she said.
Thanks, Susan, for that. And I'm glad that was a seamless transition. That is ideal. And you can kind of see, we'll talk through this. It's a bit of a complicated slide, but in the U.S., that hospice that your father, brother, your relative experienced is at the very end of life. So in the U.S., it's driven really by Medicare requirements. Hospice in other places is different. It has different criteria. In the U.S., it's driven by Medicare because Medicare is the primary payer for hospice. So Medicare says, you qualify for hospice if a doctor says that you likely have 6 months or less to live. And that doesn't, doctors aren't always good at predicting this stuff. So that doesn't necessarily mean that your life expectancy is 6 months or less. But it just means that in their best judgment and under the medical conditions, and there's criteria, as you alluded to, that the life expectancy is 6 months or less. And so really you can imagine that hospice is designed for people who are at the end of life in the last 6 months. It also has implications for other medications and treatments that you would get. So for instance, if someone decides to do hospice and they're in the last 6 months of life, then they're not going to necessarily also be doing medications such as chemotherapies or more advanced medications for heart disease or kidney failure. They're not going to be doing dialysis if the reason for hospice is kidney disease, because it's basically saying, I have 6 months or less to live. I'm choosing quality over quantity. I want to be at home. I don't want to go back to the hospital. And I'm going to forego these other treatments that might give me more quantity or more time but less quality. So if you're doing those other treatments, you're often spending time, going to appointments, you're spending time going to chemotherapy or going to dialysis, you're experiencing the side effects of dialysis or the side effects of chemotherapy. So it's a really different philosophical approach when a patient gets to the point where they want to do hospice. I'll also say that even though hospice, the requirement is 6 months or less to live, in terms of prognosis is what we call that, kind of the life expectancy, people can be on hospice for years. And the reason that is because Medicare requires the hospice to look at people at certain intervals every few months to say if they still qualify for hospice and if they're either staying the same or getting worse or getting better. If they're staying the same or getting, declining a bit, they can stay on hospice. They have to be declining a bit, which some people that looks like staying the same. But so declining a bit, they stay on hospice. And so you can go on hospice for another 6 months, and people can be on hospice for years as a result of that. Or if people are getting better, they graduate from hospice, and hospice is required by Medicare to say, you know what, this person's actually getting better. What we thought was their prognosis is not that, so then they would graduate. So hospice is that last part of life. Palliative care is not just the last part of life. It's a larger umbrella, and it has nothing to do with what your life expectancy is or your prognosis or how much time the doctors think you have left in your life. It is more focused on anyone who has a chronic disease or a debilitating disease, and making sure that the quality of life and the experience is as good as possible, as well as doing some logistical things that we'll talk about. Palliative care is covered by traditional insurance, so it doesn't have to adhere to those strict Medicare criteria and rules for hospice. Focuses on quality of life and really personalizing the care experience for each patient. And it can happen alongside any other treatment. So people get heart transplants and they have palliative care alongside that. They're on dialysis and they have palliative care. They're on chemotherapy, radiation, and they have palliative care. And so you don't have to decide to stop certain treatments in order to do palliative care. You can see there in the middle circle, the commonalities, all of them aim to reduce stress, not just for the patient, but for the loved ones around that person, and really try to manage complex symptoms and priorities in the setting of serious illness, and provide not only physical, but also psychosocial, psychological relief and a sense of peace. When it comes to home health is when you have services come to your home, such as a nurse, physical therapy, occupational therapy. That generally happens for anyone who is homebound. So usually insurance requires that you have difficulty, like you have to use a walker, or for whatever reason you can't easily leave the home, then you can qualify for home health. They generally are coming for a specific reason that a doctor orders, so physical therapy or blood draws or checking how someone's tolerating medications. Anyone who is homebound and needs home health can get it at any stage of an illness, as long as, it has to be approved by insurance. But home health is kind of unrelated to where people are in their disease journey. Home health also can often be, the agencies that do home health usually do home health and often hospice. So as people who have a life-limiting illness, the home health agency may become their hospice agency when they are what we call hospice appropriate, or when hospice is the best choice in terms of achieving their goals. And so in terms of thinking about, well, when does someone go from home health to hospice? In part, it would be around life expectancy. So if a doctor thinks that the person has 6 months or less to live, but also on the philosophy of care. If someone's, decided they don't want to keep going back to the hospital if they get sicker, that they want to stay at home and be made comfortable with their family. So it really is that shift in approach for a patient and family, but also the doctor's prognostic or the doctor's ideas around how long someone has to live. I'll stop there because that's kind of, it's confusing. So I want to pause and see what questions come up or comments around the difference between palliative care and hospice.
So I have a question. Given my experiences with that palliative care team in the hospital, do they often call palliative care, even though it's covering both essentially hospice and the more palliative traditional definition of palliative care? Because it was clearly she was at end of life, but they called it a palliative care approach.
Yeah. We just do that to confuse everyone. No, it's actually that hospice is an agency-based service. So generally hospice is done by hospice agencies, and while a healthcare system like St. Luke's has a hospice, there's also a lot of private hospices and nonprofit hospices in the community. And so hospice doesn't do consults in the hospital. So when someone is in the hospital and they're very sick or they're having a lot of symptoms, then it's the palliative care specialists that get called to do the consult. Then based on their conversation and what's going on with the patient and what the patient and family want, they will reach out to the hospice agency, who has a doctor, nurse, social worker, chaplain, case managers, bereavement coordinators, and others. And so palliative care may reach out to hospice if it's appropriate, but there's also a lot of palliative care consults in the hospital that don't result in a referral to hospice. So that's why if you're ever in the hospital, they're going to call it the palliative care team, even if it's at the end of life. And the board certification in the US for hospice and palliative care is a joint board certification. So that also adds to confusion, because you'll see that like my board certification is palliative care and hospice. Palliative care is the umbrella term. And I'll kind of show this on the next slide. It's like you can kind of think of it as concentric circles, but palliative care is the umbrella. So all these things fit under palliative care. Because they're all different types of palliative care. Palliative care is the broader term. And then you can see here, palliative care is kind of the house within which hospice sits. And in this descriptor, they are breaking it down into end-of-life care, which is where hospice fits. But then terminal care, that's what they're calling the last hours to days of life, which we would also call that actively dying. But both of the blue, the end of life and the terminal, would happen in a hospice context. And then the palliative care is much broader than that. So even for people who don't qualify for hospice or aren't actually at the end of life.
Thanks for the clarification.
Does that answer?
Yeah, it does.
Yeah.
Excellent explanation.
Yeah.
Other questions or comments on this particular? Okay, Susan's asking. Okay. So yeah, Susan brings up a good point. So Susan's asking about Idaho hospice agencies and do they provide care inside the hospital? So, and that in California, she experienced that. So that's a great question, Susan. So there are designations for hospice patient that's called general inpatient, or GIP. This is when a patient is signed up on hospice, but they're in the hospital. This happens in one of two ways generally. Number one is that they're already on hospice and they're at home or in a nursing facility or assisted living, and their symptoms are not being controlled at home. And despite the hospice's best efforts, they cannot get the symptoms controlled outside the hospital. So then Medicare will approve a GIP stay, which is where the patient's brought into the hospital to control symptoms. The symptoms, and then they stay in the hospital for a few days, get the symptoms under control, and then go back to the other setting generally, unless they're going to pass away in the hospital. The second time it happens is when a patient's in the hospital, they come to the hospital for whatever reason, they're not already on hospice. They decide that hospice is the best fit for them. They start hospice, but their symptoms are uncontrolled. And so then they just go straight to GIP. So they go from being a hospital patient to a hospice patient inpatient. There also is a variety of different types of arrangements where you actually have inpatient hospices. I will say in California, where I actually came from, these are much more common. Here in Idaho, much rarer. There is not really inpatient hospice. GIP is much rarely less utilized and less common. St. Luke's and other health systems are working on an inpatient hospice designation. And the reason for that is because if you can get people on hospice, even if they can't leave the hospital, because sometimes people can't leave because they don't have caregivers at home, they don't have a place to go. If you can get them on hospice, even in the hospital, then they can get all the benefits of hospice. And those include 12 months of bereavement support for their family members and loved ones, and just a lot more specific help than what usual hospital teams provide. So that I do think in the next, 2 to 5 years, we're going to see more inpatient hospice in Idaho, but it is a newer concept here.
Well, and the other thing is we don't really have any true hospice houses or homes in Idaho. We come close with one, Luna House, which is technically an assisted living that provides care for end of life. But yeah, so we have opportunities in Idaho.
Yeah. So in many places, there's hospice houses. There are residential type facilities that are licensed differently to provide hospice in a more home-like setting. But we don't have those except for Luna House. And then the VA has it's not really a home setting, but the VA has a hospice facility on their Boise campus. I think in the next decade, I anticipate we're going to hopefully see a lot of growth in this area. It is so nice when there are options for where people can do hospice. One of the reasons that this all comes about and is important to be mindful of is that hospice is not 24/7 caregivers. And when people are, in the last 6 months of life, I would say, 60 to 70% need to have someone around 24/7 almost. That there are people on hospice who don't need that, who are walking around driving, but I would say there's a lot of folks who need to have someone around. And it can just be very challenging for families, friends, and just, even extended family to do that. And so then people end up having difficulty with where they will go to actually do hospice and have adequate caregivers. Hospice generally comes in, I would say, you can rely on it about 3 times a week. There is continuous care and there's daily care and things, but what hospice does is really they come in average 2 to 3 times a week, more frequently if someone is having a lot of symptoms. And they provide the medications, they bring them to the house, there's a doctor connected to a nurse, so all the care decisions happen right in the home. The patient doesn't have to go out anywhere and to do the symptom management. They bring all the equipment, the durable medical equipment, the bed, commode, oxygen. They provide chaplains, social work, bath aides are really the main caregiving they provide. There's also hospice volunteers that can come in for a few hours to allow family to go out and shop or something, but they're really not the constant caregiving that people need. They don't, like change diapers or do, a lot of care like that. So there has to be a family or friend or community structure to help take care of people on hospice, in addition to the hospice agency.
Well, and that is to not preclude that hospice can happen in an assisted living, it can happen in a memory care, and it can happen in a skilled nursing facility. So people don't have to be in their home if that's not fit for them.
Yeah, that's a great point, Dee. So there's a lot of, a lot of you here, I think, are part of those experts that help our community navigate this, but there's a lot of different living arrangements, like Dee's mentioning, assisted living, skilled nursing, where hospice can happen. I think some of the challenges that folks face are financial in that way, and because the hospice benefit is a Medicare benefit, so it's really getting the most out of Medicare if it's the right choice for folks. But the facilities often are not covered by any of the usual insurances except for Medicaid. And so folks, this is what you guys do. I don't want to explain to you what you guys do, but some of you may, some of the guests may not be aware that, Medicaid is the main payer for longer term care or skilled nursing care, care in a skilled nursing facility that is not oriented to rehab. And so folks have to navigate that system of how to qualify and get financial support for that. Also, private caregiving. Yeah, go ahead.
No, go ahead.
No, go ahead.
I was just going to say, I have one little old lady, I believe she's 99 at this point in time. She came to me when she was 98, and she's been off and on hospice probably 6 times. Actually, I think she's Brooke's client that's on with us. And she goes downhill, and then she rallies and she gets up and she goes to the dining room again, and it's just amazing. So it is intended for end of life, and we thought that she was there a number of times, but sometimes that extra care is enough to kick you back up to the other side.
Absolutely. And, I know we're talking about palliative care today, but hospice, actually, many people live longer on hospice. And we think that's because of the attention to quality of life and kind of the spiritual and just psychological component. But yeah, doctors are not, it's hard. We're trying to look at what's in front of us, look at trends, in a person's life. But people have their own journey, their own timing. And I do appreciate that about the Medicare hospice benefit, is that it allows for folks to go on and off of it. And some people even decide to revoke hospice because they change their mind and they want to go back to the hospital. And that's really quite easy to do as well. And so while that's not something that, we would set out to do from the onset, I do think it's important to know that hospice is more fluid than people think. And it can be the right decision and you can qualify it for at one point, and then things can evolve. And so just for the majority of patients, they follow a trajectory, but that's definitely, there's a lot of folks that have their own journey, and insurances and frameworks for how we provide care really aren't adequate or sufficient for everybody. Any other questions about these kind of phases and layers of care, how it's related?
I still feel a little
go ahead. Yeah, go ahead.
I still feel a little confused between home health care and palliative care, but I think the more I listen, it'll probably come together. You did say the home health care was for someone who's homebound. I mean, my mother I can help her get dressed and get in the car and go somewhere, but she's she doesn't get out of the car and do anything. We're just dropping somebody off at the airport. But
so
how does it all get coordinated? Oh, sorry.
Yeah, sure. I can answer that too.
It's kind of the same question.
Yeah. So I think it's important to clarify a couple of things. So there's 3 different distinct entities that we're talking about, I think. One is palliative care, one is hospice, and one is home care. Mm-hmm. So, and hospice and home care are both types of care that happen in a home setting or wherever the person is living. Home care, though, is generally when someone has a need that the doctors see, and they can be anywhere in their lifespan, and they have a need for some sort of skilled person to come into the home. That could be a nurse, that could be a physical therapist, that could be an occupational therapist, a speech therapist. There's going to be a reason why a doctor orders home health for a patient. In terms of who can get home health, the insurances have to approve it, but what you're describing, I don't know your mom, but what you're describing is exactly what would qualify for someone. So anyone who needs like extra help getting out of the house, like anyone who's not completely independent, they can't get dressed, get the car keys, go to the car, drive the car by themselves. If they are using a walker or wheelchair, if they need help getting dressed, if they can't drive themselves, that's all qualifies. And insurances will have ways around this, but generally that qualifies for being homebound. And I'll pause because I know we have a lot of experts on this presentation, but Dee or anyone else, do you have other ways of describing how homebound is determined and what home health does?
So I think you did a good job of it. I think the piece is just understanding, because I know, Holly, you mentioned that you take your mom to a Mind for All season. That shouldn't rule you out or her out from being eligible to use home health. It is a great benefit when the providers can come to her and do the therapies that are needed or the nursing care that's needed. So if you need some specific help on that, I'm happy to help you afterwards with a call. We can do that. But many times it's more helpful for them to be able to go out and get out into the world and go do their therapies out with other people and interact. But when they can't do that, that's when that qualified benefit kicks in to have home health.
It's starting to come together. I do have one other question, because you mentioned end of life. Like that is, can you give us the definition of end of life, or how do you qualify for that? If there's...
Mm-hmm. So home health does not have to be at the end of life, and generally it's not at the end of life. Home health is when you actually anticipate someone's going to get better, or they're going to stay the same, or they're going to improve if they have a certain service. So if I have a patient who had a stroke and they need physical therapy to walk better and not fall, but yet they can't get out of the house because they can't drive, and then I would order home health to take the physical therapy to the home to work on getting them stronger. Mm-hmm. And so the goal there is they're going to get stronger, not they're going to continue to decline and get weaker.
Right.
When doctors start to see that our tools are not working to get someone stronger or to get someone better, then we start to question whether they are at the end of life. And there's a lot of research in variety. If you have a certain type of cancer, we have data on how we figure out if you're at the end of life. If you have lung disease, we have certain, how much oxygen you're on, how far can you walk, are you losing weight? There are pieces of a person's, what's happening with a patient where doctors can start to say, what this looks like is the end of life. And again, how long is very, sometimes difficult, but we have criteria that for hospice that's determined by Medicare to say when someone qualifies for hospice, meaning 6 months or less to live, in the best estimate of the doctors.
And that
answer your question?
And that is disease specific. So it's not necessarily one definition across the board. So each disease has their own specific criteria for qualifying for hospice.
Mm-hmm. So if someone has dementia, they have to have a certain severity in terms of how much they're eating, how much they're talking, how much they're walking to qualify for hospice. But even if they don't meet the hospice criteria, they may qualify for home health, because I may say as a doctor, this person with dementia is not swallowing well and they need speech therapy. And so but they can't get out of the house, or it's a lot for their family to bring them out of the house. So I'm going to send the speech therapist, which is through the home health, to the house to work on their swallowing. And so I anticipate they're going to get better if they get that speech therapy.
So just on that note, home care is not prescribed by a doctor and not covered by Medicare. Home health requires a doctor's order, is ordered by a physician, and does get covered under Medicare or most insurances.
So home care, I think what you're meaning by home care is home-based caregivers and other assistants at home. And that is, paid for through a variety, private pay, or if there's long-term care insurance, sometimes that helps. And Dee's the expert in this, so I'm not going to speak out of turn, but home health is like you're saying, is ordered by a doctor. The other point I want to make is that home health and palliative care can happen simultaneously. And often they do. And that's because you can have palliative care at any point before hospice. So generally palliative care will sign off when someone goes on hospice, although if you have a relationship with your primary care, with your palliative care provider, they're not going to, they'll be available still to you. But generally it's kind of a transition from palliative care to hospice. But during that time, then someone's in palliative care, they can have home health, which is ordered by a doctor, and that may be ordered by the palliative care doctor or other doctors. I just ordered it yesterday on a patient because the patient's goal is to be able to take walks. And right now with their arthritis, they're having a hard time doing that and they're homebound. So ordered home health, physical therapy to work towards that goal. Home care can happen at any point, any time when people need more help and more caregiving than what can be provided by their family and friends. And so home care is much more, that's fluid and at any point that people need extra help.
I personally like to call it personal care just so it doesn't have home in it, but I'm not in charge of words, so.
Well, I'm sorry. I'm envisioning a slide I should have put into this to differentiate these, but the language is so confusing and it overlaps so much that these questions are totally relevant and it's hard to really break it down. I think what I would recommend is if as trying to put together this type of to put these pieces together, that's where seeing a palliative care team or working with an advocate, a health advocate like Dee, can help you kind of come up with a plan, for how are we going to get mom, dad, husband, wife, child, whoever it is, what they need, and how do we leverage insurance to the best of our abilities in terms of getting things covered? How do we allocate whatever resources or savings we have? How do we think about programs that we haven't even, heard of or enrolled in? So there's those types of folks can help with that.
I'll send Dara a chart that I use with clients and families that differentiates the three. I'm going to have to go back and figure out how to add palliative care to it, but I've got one that's personal care, home health, and hospice. And I can put that out there in the handout section. So you'll have that to help as a tool, and I'll work through the palliative care one.
Great. And I'm happy to help you add it. I'm excited we're going to make these handout, and I have a golden retriever on my lap, so I apologize. So any other questions about how these palliative care, hospice, home health go together?
Holly, did you have a question?
I think I understand it a lot better now. But is there palliative care for mental health issues?
So that's a great segue too. I'll talk a bit about what symptoms oftentimes palliative care focuses on in terms of like the impacts of palliative care, why it's important, why it's a good thing. There's data about increase in quality of life and decrease in distress symptoms, but also the psychological experience of disease. And a majority of patients who engage in palliative care recommend it to others. So what symptoms do we actually take care of? There's a lot of them, but this is a sampling. Things like pain, nausea, vomiting, anxiety, depression, bowel issues, breathing issues, appetite issues, sleep issues. So really, if you think about the 24-hour cycle of our life, all the things that are important to how we experience our day and our quality of life. In terms of mental health, it's extremely common when we have chronic illnesses or life-limiting illnesses to have mood issues or they're actually normal responses, but they can be unpleasant. Also, if there's underlying mental illness, those can be exacerbated or worsened as a result of symptoms and as a result of the situation. And so while a palliative care doctor isn't a psychiatrist, oftentimes we will use medications or psychotherapy or other things to help with mood issues. Most commonly, it's depression or anxiety, but there can be others. Or we will, if it's a severe mental illness, if someone has psychosis, psychotic, if they're seeing things that aren't there, or hearing things that aren't there, or suicidal, then we will work with our psychiatry colleagues. But palliative care will manage on their own a lot of these disorders. Questions about the symptoms that I'm mentioning?
Well, I know that you just helped us with a client situation that we have. So thank you, because I hadn't thought about it, Holly, in terms of mental health, but we have a client who has some significant mental health issues. And before we can even kind of like get down to some of the other cognitive health challenges that we have, we've got to address the mental health. And it's like, okay, let's ask for a palliative care team.
That sounds good. So I have a question. So my mom has a few of those things on your list. So if I had her work with someone from the palliative care, then would you think they have more to offer than just her regular primary care physician who has taken over the antidepressants and things like that? Because we just weren't happy with any of the services we were getting from psychiatrists.
So I think it's a great question. I think it really depends on the primary care doctor's areas of focus and strengths and kind of how the art of their practice. Generally, palliative care and primary care work hand in hand. And so we would want to complement what the primary care doctor is doing. If the primary care doctor, oftentimes palliative care, the specialty training, so we go through additional training, either board certification or fellowship and board certification. We will often be trained to use medications that primary care is less comfortable using, or using medications in different ways, different doses that primary care may not have as much training in. So sometimes we're bringing just another layer of input, but we really want to coordinate with the primary care doctors. We're generally not taking over primary care, but we work out kind of, okay, I'm going to focus on these symptoms and I'm going to make some suggestions. Like because we're consultants or specialists, sometimes we'll make suggestions to the primary care doctor, but they'll make the actual changes. Sometimes, I'll connect with the primary care doctor and be like, I'm going to do this, this, and this. Is that okay? So we really try to integrate the care and make sure that we're not being contradictory.
Sounds good.
And if I could just jump in one more time, the other piece about having home health sometimes is there are home health psych nurses that can be incredibly helpful when they're in the home and they see what's going on in the home. Some of us can put on a really good face when we go out and we meet with the doctor. But it's a little bit different when they come to you. So keep that in mind too, that could be something that is also helpful with home health as part of this whole team, is that psych nursing piece.
Good.
Yeah, that's really helpful. And I think too, palliative care really tries to disentangle what mental health issues are happening as a result of physical illness or symptoms, or how is that worsening the mental health situation. We're good at disentangling that a bit and being able to come up with a plan that's holistic. So Susan asked, are there limitations or restrictions to the medications palliative care can provide outside the hospital setting? So, so palliative care is going to use symptom medications to the extent that it doesn't cause people to be too sleepy or have, secondary issues. There are certain medications and interventions that can only be done in the hospital, like those that require an IV or those that require special monitoring. But in general, the toolkit of palliative care is based, is based in the outpatient setting. And when people are inpatient, we might change a medication that we would use outpatient as a pill. We might make it IV, but generally the medications are all stuff you can do at home. And the reason is because we want people to be able to leave in the hospital and still have the relief. But at times they become, we have to use things IV for at least a short period of time to get things under control. So for instance, someone may be on IV pain medications in the hospital, and then as they get closer to discharge, we put them on pills to make sure, or patches or sublingual under the tongue liquid. So we'll start that at the end of the hospital stay and then continue it when they leave the hospital. So what else do we actually do? Well, beyond symptom management, we focus a lot on kind of the patient's unique goals and desires and philosophy around their medical care. We want to help patients and families make difficult decisions. And like Dee mentioned, like really zooming out, the 30,000 foot view of what's going on. It can be, there's a lot of amazing doctors that are focused on their organ system, whether it's the heart or the kidneys or the brain or the blood. But it's sometimes hard to get someone to pull it all together and to kind of really give as holistic and as transparent of an assessment and understanding as possible. And so oftentimes that's what we do is we synthesize all the specialists, what they're all saying at their various visits or their encounters with the patient. We try to synthesize that and then, discuss what's going on in a way that's really trying to take everybody's perspective into account and balance different things. I'd say also we can read between the lines. So sometimes it's difficult for all doctors to talk frankly about a situation, particularly if their medications aren't working well or they don't have medications or treatments that are going to work well. And so instead of saying that, they may, tell the patient, we're just going to keep doing what we're doing, or they may try medications that don't actually, have a lot of benefit. And, it all stems from a really good place of being oriented to getting people better. But our doctors don't have as much training or sometimes comfort in what do we do if our medications aren't going to make people all the way better, or if they're going to make people sicker in some ways and less sick in others. And so I think the palliative care specialist is going to be the one that will help you kind of get as authentic and transparent of an understanding as you want. So these conversations are not forced upon people. If people don't really want to go there, that's fine too. The palliative care providers should have the skill set to, be able to ascertain how much do you want to go into what's between the lines versus not. But to be able to read between the lines of what the other doctors are saying and try and pull it together in a way that you can help make better decisions or feel more informed. Or plan, like people want to plan their life and it's like, well, should I do this trip now or can I wait a year or 2 years or 5 years? Am I going to see my grandchildren graduate or not? And, just having some roadmap. In addition, we often are assisting with advanced care directives. So advanced care planning, these are commonly known as like living wills, power of attorneys, but also what's called a post or post form. So these are the doctor's orders that go on the refrigerator at home to let the ambulance and the emergency room know about people's preferences. These are particularly important when people want limitations in how invasive or aggressive they want people to respond when they get very sick. So, for instance, we'll often talk about certain scenarios. So, if your heart stops or you stop breathing, would you want CPR, the pushing on the chest? Would you want intubation, the tube down the throat that connects to the life support? Shocking medications? Or if that happens, do you want to be left to be natural and pass away without those interventions? So we'll kind of talk through that and also make sure that a person has designated a surrogate, which is like a next of kin, a person who will speak when you can no longer speak for yourself or will assist in decision making. Making sure that that surrogate, number one, is identified, but number two, has an understanding of a person's wishes and knows them enough, and specifically some of these difficult conversations around what ifs, that those have happened to the extent possible. The reason for that is we don't want to necessarily leave our child or our spouse or whoever our surrogate is. We don't want to leave them without ideas about what we want, particularly if we have strong feelings. So these are some of the other things that palliative care actually does. I'll pause there for any questions or comments. Okay. And then the kind of how, sorry, go ahead.
Sorry, in the chat, is there a palliative care physician in St. Luke's, WRV? I guess that's Ketchum and or St. Luke's twin.
Yeah, so Dr. Prusel is in St. Luke's Twin Falls in Magic Valley. In Ketchum, there is a community-based hospice and palliative care that works with our hospital there and in the community and with the primary care doctors. We actually at St. Luke's have launched the virtual palliative care program. So we now, and I run that program out of our virtual care center in Boise, we can camera in and do consults or do care for any emergency room, for most inpatient rooms. And then we have virtual clinics, outpatient clinics, either by camera, phone. So we're really trying to become much more accessible. But Dr. Prusel would be the person in Magic Valley.
Thank you.
Yeah. So the how, so like, what are some of the assumptions that are behind this care? One is that palliative care physicians and teams really regard death as a normal process. And so that comfort with that normal process that will eventually unfold, I think, informs all the things we do up to that point. We want to help a patient live as actively as possible, to have as much quality of life as they can and they want. We integrate psychological and spiritual aspects of care. We help families cope and patients cope during their illness and kind of go through, oftentimes there's grief before there's there's different types of grief, and grief that happens early before someone even gets so sick that they're going to pass away, but there's fear and grief and frustration and anger and sadness. And so we sit with those emotions. We face them with you, and we understand that those are normal, and we're here to help and support and just create space where that's okay. And then, as we mentioned, we can help at any point throughout an illness. Some common conditions we see, I think I've mentioned a few of them. Cancer has a dedicated palliative team within the St. Luke's system, but that is a common diagnosis too that get referred to palliative care. But also neurologic diseases, heart failure, diabetes, kidney failure, liver disease, dementia is another common disease that we see. And where might you see us? Well, each health system is different, but Vic Bartlett is the director over at ALS, and they have inpatient and outpatient. When you are admitted to the hospital, as we mentioned, palliative care is going to be the consultant that the main doctor asks to see you. And as an outpatient, usually you are referred to palliative care from your primary care doctor or one of your specialists, and then you see us in a clinic. As I mentioned, we have virtual care now and telehealth, both for inpatient and outpatients. Home-based care, so St. Luke's just started an expansion to home-based palliative care. And so I think meeting, for those people who are homebound or where what's going on at home is really influential in their quality of life or their experience of their disease, we're going to bring palliative care into the home. And then palliative care can happen at skilled nursing facilities, assisted living, other types of residential facilities. And why might you feel reluctant to see a palliative care specialist? This can be, oftentimes patients will come for their first visit, as I mentioned, with a bit of fear, expressions of fear on their face. They're not quite sure, number one, why have I been referred to you? What are you going to tell me? Is this going to be bad? And so I think there is a reluctance, and I totally understand it. It can be really difficult to discuss suffering and quality of life issues. And even though palliative care providers and teams may consider death to be a normal process, most of us have fears around dying, of losing our loved ones, or discussing death, or discussing what may happen between now and when we pass away. I think there's also fears that the medical system will give up on us, that if we start to set limits and what we want, that we won't get any care, and that can be really scary. And it can be sad to discuss how our health and lives are impaired, how we can't be ourselves. I wanted to open it up. Are there other experiences you've had or that you can imagine why folks might feel reluctant to see a palliative care specialist?
Well, mostly because they don't understand what it is. So.
Right.
Yeah,
Or they
for
think
sure.
they're giving up. They're not ready to give up, like you said.
Yeah, and they're thinking that it's giving up or somehow losing hope. And it's hard to imagine having these conversations alongside holding hope and having the opportunity to get better. But in fact, that is what happens. And then what can you feel after seeing a palliative care specialist? So once we get the courage, some people need that courage to do it. How are they impacted? Well, obviously improvement in symptoms. Also an understanding of the prognosis or trajectory or what may happen in this journey. Oftentimes, we're giving actually more positive, rosy news than folks think. They think they're coming and it's going to be like all bad news. And so I think there's a certain relief, and often it lifts people up, because we can say, no, actually, like, you're going to be okay for a long time from this, and it's okay. And having an ally in your court when you're navigating healthcare. So healthcare has gotten to a place, I'm sure many of you have experienced it, where it's fairly rigid. It sometimes isn't as patient-centered as we would like, or it should be. And I think palliative care is still a specialty that's a little bit sheltered from the kind of push to see a lot of patients in a short amount of time. So palliative care doctors, generally our appointments are anywhere from 60 to 90 minutes. We only see a few patients a day. And so you really get to spend a lot of time with the doctor. And that builds this ally in your court who understands what's going on with you, can help, like Dee mentioned, even help get you into specialists that maybe haven't been accessed yet. So we are really a partner for you. And the additional time. Taking care of documents can be helpful. I think that can often be hard to confront. My own mother just got diagnosed with metastatic cancer, and she actually did her living will yesterday, and she was terrified of facing that, and she did it, and she feels really good about it. And so I think just the relief of facing that, of taking care of those documents, but also of letting your family or friends, loved ones know what your wishes are in the event that you have a serious condition or your body is shutting down. It's obviously a super distressing situation for your family or other loved ones. And so I think the more that clarity we can bring in advance and outside of that very high stress situation, the better. Otherwise, our surrogates or family or friends can be left kind of guessing or even, going off their own wishes. So of course, no family member wants to lose their loved ones, but the role of the surrogate is to represent what you want, not necessarily what they want. And so by having those conversations up front, what you want is in the front of their mind. A medical plan that reflects your priorities and wishes. So we're all unique people, and healthcare doesn't always let us be super unique. So palliative care is one of the opportunities to do that. And I think giving more control over what's happening and what's going to happen, what medications are important to you, what medications you don't like. So oftentimes, people really don't want to take X, Y, or Z, and we can get them off those medications.
And Dr. Everett, just so you know, we need to wrap up by about 5:30.
Yep, perfect.
Okay.
Perfect. So just wanted to bring some examples forth on kind of some ways that palliative care can also change the course of your healthcare experience or those you're working with or love. So oftentimes I find that there are choices that exist that maybe others don't bring up or don't call out in a certain way. An example is Richard, who's 86 years old and has some high blood pressure, but it comes to the hospital with a stroke, and the stroke has affected his ability to swallow safely and eat. And so the doctors have the order in, the nurses are saying, you can't eat. The doctor's order says you can't eat anything, and Richard really wants to eat, and he gets the most enjoyment out of his morning coffee and his cream of wheat. And he asks the doctors if they can let him eat, and they say it's not safe. Richard's daughter comes, Emily, and she's a physical therapist, and he tells her how much he wants to eat, and she's familiar with palliative care, and so she asks the doctors to have the palliative care physician meet with her dad. And the hospital doctor tells Emily the only way your dad can get nutrition is through a feeding tube. And so the palliative care specialist comes and meets with Richard and Emily, and they discuss the risks of eating, which is in part aspiration, food going into the lungs rather than the stomach, which can lead to pneumonia and failure of the lungs. But Richard tells the palliative care doctor that he really wants to eat, and even if that's going to happen, he'd rather eat and enjoy his food in the time he has left rather than get tube feeds. And so he decides he wants to eat. The palliative care doctor speaks to the hospital doctor and says, we should allow him to eat, and also creates documents to express Richard's preferences around intubation, which is going on the breathing machine, which he wants to avoid. And so, even though he'd been getting messages that he's not allowed to eat, that it's not okay, with a little bit more nuance and discussion, Richard kind of learned that he could eat and what that would mean, and was able to do so. In addition, particularly with COVID, but even before COVID, communication can get very clunky, especially when people are in the hospital and family can't visit. At St. Luke's, our palliative care department is called Palliative and Supportive Care. And that supportive care function is really important because we really serve a wider function at St. Luke's of helping support patients who are experiencing extreme distress from the actual hospital stay or families. An example is B, who has COVID-19 pneumonia. She's on a ventilator. The hospital policy isn't allowing her family to come visit. She has a husband, 4 children, and a sister that she's really close to. A single family member is getting updates from the nurse daily and then having to pass that information on to all the other family members. And the hospital doctors are calling every couple of days, but the family doesn't feel like they understand what's going on. They're also concerned that the doctors aren't doing the right things for B, and they are also concerned that the hospital actually get paid more if B dies from COVID rather than if she gets better. And so they're questioning what the intentions of the hospital are. Palliative and supportive care at St. Luke's would help B and her family and navigate this and understand what's going on. So the support function of palliative and supportive care at St. Luke's is where we really serve to bridge communication between the patient, family, and the care team. We're able to spend more time giving updates, and we can do so to a wider group of people. So rather than just one person getting information and trying to pass it on, palliative care will actually get, multiple family members on conference calls or bring them into the hospital to meet in person. And so then multiple family members can ask questions directly, can get updates rather than just one point of contact, which can make things difficult. But also listening earnestly, I think, to concerns, distrust, and acknowledging dissatisfaction. Healthcare is a high-risk situation. There's a lot of medical errors. There's also a lot of dissatisfaction with communication, and this has been made worse during COVID for a variety of reasons. And so the palliative and supportive care team at St. Luke's is designed to not just do palliative care, but also to do supportive care and help people navigate and feel and get better communication. And then advocate for the patient and the family with the wider healthcare team. So really being a spokesperson and advocate for where people are coming from. And I would say de-escalating when there's been an escalation between the doctors and patients. I just want to bring up one other construct before we close, which is evidence-based medicine. So evidence-based medicine's been around for a while. It's really kind of the paradigm that doctors use to make decisions. And a lot of times when you hear the word evidence-based medicine, you think of research and evidence in terms of data and things. But in actuality, evidence-based medicine is the nexus between scientific evidence, clinical judgment based on a doctor or healthcare team's prior experience, and as well as patient values and preferences. And so I really see palliative care as bringing that blue circle to life and making sure that it gets its place in how decisions are made, that decisions aren't just made based on research and aren't just made based on the doctor's opinion, but also take into account the patient's preferences, values, and that of the family as well. So back to our patients we met at the top of our time together. Marcia is having heart failure, and she's having difficulty breathing, not being able to go to lunch or church. So with Marcia, we were able to get her on oxygen, to get her into cardiac rehab, and she's now able to go to lunch and to church weekly, and really is enjoying life. For David, who has COPD and is on oxygen and has started to lose weight and get weaker, we're able to start him on an appetite stimulant. We're able to stop some of the medications that had been started years ago that actually can reduce strength, and send home health out to do home physical therapy with him and get him stronger. For Donna, who is living with liver failure, waiting for her transplant, we're able to treat her symptoms of itching, her confusion with medication, and her abdominal pain, but also able to address some stressors at home that were happening between her and her mother and her daughter, and create a dynamic that was more supportive for all of them and able to process some of the frustrations that caregivers and the patient were having. For Emmett, he's 98 years old, and he is in the ER wondering whether or not he should get this surgery, and the orthopedic doctor says we can do the surgery, but it might not be the right idea. So the palliative care doc meets with them, and Emmett's having a lot of pain, and so we talk through how the surgery actually, although that it is invasive, will lead to substantial decrease in pain. And Emmett decides he never wants to go to a nursing home. He never wants to go to rehab in an inpatient setting. And so he gets the hip fracture repaired, and then he decides he's going to go home on hospice and not rehabilitate from a physical, functional standpoint. So those are some examples of what palliative care can do and does on a daily basis. I am giving you my email, and then there's the phone number to our clinic staff who can connect us. If you have any referrals or if you just want to talk more, please reach out. And I think I left a few minutes for questions, comments, and thank you again for having me.
Are there questions, comments for Dr. Evert?
So the first thing to do would be contact the primary care physician. I know she would be cooperative to send a referrals so that we could have an evaluation with you. Okay.
Yeah. So just ask the primary care doctor for a referral to St. Luke's Palliative Care, and they just fax it over. If they're on Epic, then we would be on a shared system. If not, they can fax it over. I'm sorry I didn't put our fax number there, but they can access it online. And also the primary care doctor is welcome to reach out and talk through things as well. But generally, most primary care doctors are very willing to send referrals to palliative care, and we have a really good working relationship. So that would be the first step.
So my mother, she put in, her doctor did give a work order or put in for palliative care for her, and we haven't heard anything back yet. So we were kind of concerned on that, if there was a different avenue we should be going through.
Yeah, was that through St. Luke's?
It was through St. Luke's. It was actually, she had two doctors do it, her heart doctor and then her regular physician.
Okay, perfect. Would you feel comfortable emailing me her name and date of birth, and I can look into it for you?
I will totally do that. Thank you.
Okay, thank you. And I apologize. Usually people should get a call back within a week of us receiving the referral. So if that hasn't happened, I apologize, and definitely will look into it. But the timeline generally for getting into us at St. Luke's is that the referral sent over within a week or so. You should hear back from our Jordan. McGuire is our medical assistant, and she does the scheduling. And then the choice is to schedule. We have clinics Tuesday, Wednesday, Thursday, and Friday. We have physical clinics in Boise and physical clinics in Meridian, and then we have virtual clinics, obviously wherever in the state of Idaho a person would be. So, and usually we're scheduling 1 to 4 weeks out, but it's not a very long wait. So if you're not getting an appointment within that time frame, then something isn't going right. So happy to troubleshoot.
Yeah, it could have been her not answering her phone thinking it was a spam too, but she had put her phone next to her. So she was waiting for the call. So I appreciate that, because you guys don't really do, St. Luke's doesn't normally get back right away. So it just surprised me. Thank you.
Yeah, I know it's difficult. I have to navigate the healthcare system for my son a lot, and but our team is actually, Jordan's amazing, so I will look into it, but she's very responsive, and so she should be getting back to everyone promptly.
She has good follow through. I appreciate her very much.
Great
And
presentation.
I wondered, I'm sorry, go ahead.
Oh, I just said that was a really great presentation. Lots of information to think about.
Yes, it was very good. Thank you. I was wondering what Dee's title is and about her services she has to offer.
Oh, just quick, Dee is a care manager. And so you can access me through the Learn website if you'd like. All my contact information is on the Learn website. So just go to members, look at members, and I'm out there. My business is Life Changes Elder Care Consulting, and we have seen each other at A Mind for All Seasons because I recognize you. So you can also ask them.
Okay, sounds good.
All right. Well, Dr. Evert, I am so appreciative of the presentation that you've made for us today. I thank you. I thank you. I thank you. And let's see if I can get my screen back over here. It is paused. So let me see I'll tell you what, I do this all the time, and yet I still have a hard time making it work.
Technology.
I know. So let's see here. We're only going to have the host share right now. So you'd think she could pull up her presentation, wouldn't you? Let's see. Are you seeing it now?
Nope, I don't think you're sharing.
It looked like I was. Share. Let's get back down over to here. Share.
There we go.
There we go. Whew. I'll tell you what, it's a challenge these days. So I guess we're past introductions. Dr. Evert, thank you so much. You have just done a wonderful job of helping us all understand palliative care. And I know that you're very passionate about advocacy, and we all greatly appreciate your time and willingness to talk with us today. And I hope that you'll be willing to come back and talk to us at some future date about something more kind of a drill down here, because I think it would be very helpful there. I think that whole advanced directive conversation piece, you may remember that was a particular topic issue with our client, and sometimes really helping families understand that this is the wishes of their loved one. It's not what they want for their loved one. It's honoring the wishes of their loved one. And your team was so helpful with us with that. So thank you again.
Thank you. Happy to come back.
Great. I'd like to thank again our sponsors for the winter quarter of Learn Sessions, Oasis Senior Advisors, and A Mind for All Seasons. And we would love to have you all join our email list. If you will receive an invitation to confirm being on our email list. If you're not already, we won't send you any more email if you don't confirm that you'd like to be a part of our emails, which just basically lets you know what sessions are going on, and that you do need to check your junk folder just to make sure that it didn't go in there, but you will get something in the next few days. It also says that this email or this video will be posted to our website as well. The next two sessions coming up in this quarter are the Art of Long-Term Care Planning and Living Well with Diabetes or Chronic Pain. I'm not sure why it's not, but we'll get it narrowed down to one. And then we're diligently working on our spring schedule of classes, which we have all put together, just getting our materials together to get communicated out to you. So once again, thank you all for being with us. I greatly appreciate the opportunity to be part of Learn and to have you join us, and the wonderful, amazing speakers that we have join us every time we do one of these engagements. So once again, I thank you all for being here. Dr. Evert, again, I thank you, and you guys have a great week.